Welcome everybody. Now I'm the speaker. I'm Dr. Murat Altın. I'd like to give. I'm an adult psychiatry specialist. I'm working in Gazi Medical Park Hospital. My specialization was in the hospital. Then I'm still studying this adult psychiatry. I'll talk about the neurobiology of the personality disorders. When we address the issue first, actually this is a subject that we can talk and elaborate more, and we can bore people, but I'll talk about the aspects which can be effective in treatment. What happens in neurobiology, so that what kind of treatments we can give to get a result. The most important thing to understand neurobiology for me is that actually is about what to expect, to what extent we can expect from the client, from the patient, in terms of the treatment results, in terms of the expectations. If we can understand the system in the patient, we can have a clearer picture of the treatment approaches. When we consider personality disorders, personality disorders are the ones which impairs the social and professional function of the people, which causes a specific problem in the lives of patients. When we consider the Turkish community, we can say that it's 3 to 20%, the prevalence is 3 to 20%. And the most important point here is that because the socio-economic level and culture actually affect the personality disorders. As you know, with the DSM-5, there is a new clustering of the personality disorders. Actually, the same things stay the same places, but with that, while we are defining them, there is a new approach. For example, the eccentric, paranoid, schizoid, and psychotypal disorders, and there is antisocial, borderline, hysteric, and narcissistic group, which is romantic, emotional, and neurotic, and also the cluster, anxious, and fearful group, which is the dependent or obsessive compulsive group. Recently, the heated debate is about whether the dimensional or categoric approach. When we say category, it is yes or no, present or absent in DSM. However, most of the patients are within the gray area, not in the white or black area. So there is a dimensional approach which is inside DSM-5, and this dimensional approach basis is that there are different symptom clusters in the patients, and the symptom clusters based on the severity of the disorders could be very severe, could be less severe, or could be more. These symptom groups can be within a certain group.
There are 4 domains of temperament. The first one, affective dysregulation or instability. The second one, impulsivity. And third one, cognitive disorganization. And the fourth one is the anxiety. When we look at the personal disorders, among these groups, there are some clusters of these symptomization. Here, for example, the impulsivity, B-type personal disorders, and anxiety, C-cluster personal disorders. But anxiety, on the other hand, can be seen very frequently in the dystonia personalities. Therefore, dimensional approach is important. Yes, here we have this or that B group, we have this or that C group. This is not the correct approach. It should be general symptomology. And neurobiology is explaining it more clearly. The first big group, the impulsivity and aggression group. Impulsivity, aggression, actually, a lower threshold for the activation of motoric responses, particularly aggressive ones, to external stimuli, without reflection or appropriate constraint. It's motor disinhibition. And it has been seen in all dramatic cluster diagnoses in the B group. Yes, we do see aggression impulsivity on all of them, but the reasons are different. In the borderline personality disorder, for example, reactive and unstable affective modulation, which often serves to trigger an aggressive act. And these are the matters. The emotional stimulants are creating the aggression. In an antisocial personality disorder, when other people trivialize the importance of antisocial individual needs. Aggression not only in the personality disorders, but in the post-traumatic stress disorders. It might be related to the trauma, or in some other situations, aggression can appear in a psychos disease because of the cognitive insufficiency or because of the psychotic symptoms. Aggression is an adaptive response to a potential threat across a wide variety of species. Humans have evolved higher cortical functions that act to inhibit the expression of aggression when it is deemed inappropriate. And aggression, as expressed clinically, must be understood from the perspective both of the more primitive limbic systems involved in its generation and of the cortical control mechanisms. It might be either language, memory, or motor control. Briefly, the initiation and modulation of aggression. The brakes are broken. There might be two reasons of brakes broken. The car can go faster than the brakes can stop it, and second of all, there might be problems with the brakes of the car, or the speed and the brakes performance are incompatible. Therefore, the problem of the basic aggression about the personality disorder is that this incompatibility. When there is a external stimuli, sensationally we process it, and these problems, sensory disorders or visual loss or alcohol or metabolic diseases, this is distorting the evaluation and they can result in a direct aggression. Or here we do have the stimuli, and especially in the occipital region, prefrontal cortex and temporal region, there are some problems in these regions as well. And afterwards, in early ages, the processed information interferes. And depending on that, this stimuli is about the stimuli. It might be either cultural or social factors or cognitive insufficiencies like the paranoia or childhood traumas. Afterwards, when there is a problem in processing them, here the aggression appears in the amygdala region and in the limbic system. There is a serious stimulant and the system which push the brakes doesn't work, and depending on that, the social stimuli comes more than that, and the limbic system is aggravated, and there is no brake to stop that. Therefore, the aggression appears. And in the system that I just mentioned as the neuromodulator, cortical lesions or the cortical decrease or the orbitofrontal insufficiencies When we look at the neuromodulators, insufficient serotonin, and especially high dopamine and norepinephrine secretion. On the brake part, the serotonin has a controlling characteristics, but they cannot make use of that. And on the other hand, dopamine or norepinephrine hormones are high on upper part, and reduced GARA and glucomat and acetaminate increased. Therefore, as a result of that, the reaction in the limbic system is increased. When we look at the research is conducted. I'm not going to give too many details. Along with the SSRI treatment, impulsive aggression, especially impulsive aggression, not the general aggression, especially impulsive aggression, there is a substantial decrease. And again, these researches show us that the serotonin levels decrease substantially. The studies made with borderline patients show us that the substances which are expected to increase the serotonin levels, especially with fenfluramine, the patients couldn't reach up to sufficient serotonin level, and in parallel to that, in terms of prolactin level, there is the expected increase didn't happen because of a dopaminergic activation is less, especially in the borderline patients. It's connected to the aggression. If the aggression is more in the borderline personality disorder, it might be resulting from the serotonergic insufficiency, and serotonergic agents can better the results of the treatment, and there are studies proving that, and in the clinical observations, and the clinical observations also support this idea. And there are some new studies supporting it in the orbitofrontal cortex of the patients and in anterior cingulate gyrus when compared to other control group. There is a decrease because these two regions are very important in the control of the aggression. These regions are important for the control of the aggression. And depending on the increase of the intellectual capacity, the aggression can be controlled better. And one of the most frequent examples of that in the clinics, the patient comes, graduated from the Bosphorus University, and intellectual capacity is high, and his aggression is to have fight with a stick in the traffic. But when we look at that very same patient, he can control it in the office because, the intellectual capacity increase makes it that the frontal cortex can push the brake more easily. And if the intellectual capacity is less, then the frontal cortex is less capable of pushing the brakes. There is a study conducted with fluoxetine, SSRIs, especially in the orbital frontal cortex. Serotonergic activity is increased and impulsive aggression is controlled, and they are more active in that regard. They are more successful in that regard. As I stated in the previous slide, yes, in the upper system serotonin, but in the other part there is a limbic sensitivity. In the limbic region it's aggravated. In the upper part, yes, the throttle is quite weak, but there is another organization which is pushing the throttle, glucominergic and GABAergic system imbalances, because GABAnin we are expecting it to inhibit and the other system to activate, but especially when we look at its reflections to the treatment, anticonvulsants They are reducing the limbic irritability, and serotonergic reuptake is increasing frontal inhibition, the brake, and atypical neuroleptics is decreasing subcortical dopaminergic stimulation and increasing frontal inhibition, and the stimulants are increasing frontal inhibition, and opiate antagonists decreases the opiates, and especially along with the ADHD comorbidity. The stimulant treatment show us that the stimulant treatments, along with the ADHD symptoms, it is decreasing the aggression as well. And the second symptomatic group is the affective regulation. The problem with the affective regulation is that the instability shifts of the mood shifts, especially B group, dramatic one. It is more common among that. And the most prototype is the borderline personality disorder. The regulation of the emotional reaction is distorted by the amygdala hyperresponsivity, especially in response to anger-provoking stimuli. You know, the early childhood traumas or socio-cultural factors or the genetic factors, these people have amygdala hypersensitivity, because amygdala is the seat of fear and it is activated in equal measure when either positive or negative emotions are aroused. BPD subjects compared with controls, memories of abandonment have been associated with underactivity of the orbital frontal cortex, greater increases in blood flow in the dorsolateral prefrontal cortex, and greater decreases in the right anterior cingulate gyrus, ACG. In normal individuals, in response to angry faces, there was an amygdala orbital frontal cortex coupling or correlated activity, suggesting that as the amygdala is activated and the OFC comes online to modulate its activity, and it provides the balance. And BPD patients exhibited reduced activation in anterior cingulate gyrus and increased amygdala activation as compared with controls in response to the presentation of emotional faces and effectively charged pictures. In contrast to normal individuals, they don't have any correlation, it's zero correlation, so it is thought to be effective in the imbalance, emotional imbalance. The modulation of limbic structures, including the amygdala, the entorhinal cortex, and insula is likely dependent on glutamatergic, GABAminergic balance in interaction with the cholinergic system. Glutamate is generally excitatory, so this sensitivity is important. Cholinergic agents induce dysphoria in BPD patients in contrast to both healthy controls and patients with other personality disorders in proportion to the degree of affective instability-related traits they display. Valproate, which enhances GABAminergic activity, has stabilized affect-driven impulsivity in BPD patients. And this is the basic system. GABAergic activity is being enhanced, and topiramate and lamotrigine, which reduce glutamatergic activity as well as enhancing GABAminergic activity, have been reported to ameliorate BPD symptoms. As a reflection to the treatment, if the patient if a BPD patient, if there is an aggression or impulsivity enterotonergic group, and we might be talking about a brake system, and if there is an emotional dysregulation, glutamatergic system imbalance can be considered. But instead of saying that this patient has this or that, we need to be having a dimensional or symptomatic approach, so it is more correct. Many neuropeptides also interfere. Opiates have a very clear effect. Oxytocin is involved in social cognition and interaction across species and plays a crucial role in the regulation of affiliative behaviors, and the oxytocin reaction is being determined by childhood trauma. Oxytocin reaction is better with the childhood trauma, and when you work with these people, oxytocin levels are less when compared with non-BPD patients. Cognition and attention. C group, schizopital, personality disorders. Very briefly, schizotypal personality disorder, SPD, cognitive insufficiency, dopaminergic activity is the reason. However, these other personality disorders have this cognitive insufficiency. If we think that schizotypal personality, then normal personality disorders and normal controls. Here, in terms of dopaminergic activity, these people are not at the schizophrenic dimension. How can we reflect it to the treatment? Instead of giving him a dopaminergic agent, maybe some different agents might be tried. There are some recent studies conducted about the stimulants, for example, especially with these patients. The working memory and the attention, there are serious deficits in the working memory and the attention, not seen in schizophrenia, non-schizophrenia, by the way. And the other medications might be showing you the way because of the positive studies, along with the stimulants, along with amphetamine, for example. The studies were conducted. And in terms of anxiety, personal disorders or anxious cluster personality disorders include avoidant, dependent, and compulsive personality disorders. And the imaging about the brain, there is no study to explain the roles, because anxiety is regarded as a comorbidity, especially along with the social phobia patients. And as the anxiety level is quite high, and these patients are evaluated under the group of the anxiety disorders, but there is no serious studies conducted, neuroimaging studies about these patients. And when we look at them, especially in decrease of anxiety and the adaptation of these patients are increased.
This is the major problem in the patients. In general, related to anxiety, the patients experience problems, and this is there is a decrease in dopamine mechanism or a response to cortisol with these ergogenic agents, and benzodiazepines are effective in these patients. Regarding the patients in this group, what is attracting attention is in classical obsessive compulsive personality disorder patients, they may not have the rituals, or they may not have severe obsessions of obsessive compulsive thoughts. There have been some studies, and in regarding the cognitive capacity, there are problems. So the patients also suffer from some attention-related problems. And in anxiety increasing situations, regarding the stimuli control impulsive control, they experience problems, and hypothetically these agents could be effective. I have 20 seconds left. Thank you very much.